Well, hello from Vienna. We are here at the European Association of Cardiothoracic Surgery meeting, and we have Professor Peter Zilla here with us from the University of Cape Town. Dr. Zilla, you're one of the few remaining surgeon scientists that we have in our community. Started out your career, we'll have you tell us about it, here in Austria, right? And then moved along to start the cardiovascular research unit in the University of Cape Town. Do you remain the director of that today?
Yeah.
And also the chief of cardiothoracic surgery at the Chris Barnard Department of CT Surgery.
Little correction there, I'm the emeritus of the
Okay.
Chris Barnard chair, have been for the last 1.5 years.
Perfect. Well, we're thrilled to be able to talk to you a little bit about your exceptional career and also your latest movement with the Cardiac Surgery Intersociety Alliance. So can you tell us first about your background here in Austria?
Yeah, background in Austria, having grown up here in the 50s and 60s, was a very different place to today. You still had a lot of post-war wounds and scars, and it was a great place. And today it is really a little jewel of one of the nicest European cities. And after my medical training, after my basic training, I always believed that science should be a part of becoming a surgeon. So I spent a few years in basic science in Switzerland, and it helped me a lot when I came back to start my surgical training to really get the scientific part in what we would call translational medicine today. And we were very, very keen tissue engineers of the first minute, had the first series of 500 patients with tissue engineered cardiovascular implants. And with that, I sort of went blue-eyed to Africa because it sounded great. Succeeding Chris Barnard meant something for us. And I learned relatively fast how different the worlds are. Being in a big city like Cape Town means you have still half first world, half third world. And that makes it easy in the beginning because you have the same coronaries, the same ASs as you have in America and Europe. But then you have the other half suffering from rheumatic heart disease. Even the pediatric side of cardiac surgery was the same as everywhere. But the huge chunk of patients still needing surgery for rheumatic heart disease was overwhelming because everyone told me in my training that rheumatic heart disease is a disease of the past. And Cape Town developed over the decades into a hub for rheumatic heart disease research. And slowly we started to realize that it's not just a little cluster which we see here, but that it's still a huge worldwide problem. And one can say the bigger part of mankind is in need of cardiac surgery for rheumatics than for not rheumatics.
And so this must have led you to organize the Cape Town Declaration and the meeting of the minds, so to speak. And can you tell us a little bit about that?
We were lucky at the 50th anniversary of the first heart transplant. We had the who is who in cardiac surgery was there. We had 600-700 people without calling it a conference. So there was no budget, everyone just came. and we had the most extraordinary meeting. And at that occasion, we organized what we called the South-North Dialogue. Said we use this celebration to tell people what the South needs and not have the usual other direction of flow where the North generously shares knowledge, which is not always what is needed. And that was a real wake-up call. We had all the presidents of every single major society, including the cardiologists, the World Heart Federation, all the editors of all our big journals. And they all came together and said, what can we as societies do? And the logical next step was to say, let us first analyze what the needs are. And the very first step of this Intersociety alliance was that 15 countries of low and middle income social level, including China, Russia, India, Brazil, South Africa, did a thorough need assessment, and it's for rheumatic heart disease. And it's always easier to say how many patients have rheumatic heart disease than to say how many need surgery. That was a piece of information which was very, very difficult to extract from what we did. But in the end, we came to clear numbers of between 200 and 400 patients per million in these countries in need of heart valve surgery every year. And the next step was to assess where does cardiac surgery exist and what percentage of needs does it cover. And the result was again shocking. For poor countries like Mozambique, it covered less than 1% of patients in need. And even China had, and you may be aware that the two biggest cardiac centers in the world are in Beijing. Fuwai Heart Center operates 15,000 open hearts a year.
Wow.
And still, you go 100 kilometers outside the big centers, and there is the same need, and again the same rheumatic prevalence. So you have in China and India about 30% of the population covered by heart surgery. Although you see an airport opened every day. So our perception needed massive correction. And then we realized that A, rheumatic heart disease is really a huge problem, but B, that something needs to be done to make the goodwill of all our colleagues in the first world more efficient. You have hundreds of NGOs. Very often they sort of duplicate efforts. They go through the same trouble to get permissions from governments, and they fly in, operate 5 children, and then fly out again. So there comes step 3, the correction of what needs to be done different. And the very first step was the realization that everyone focused on children, but the needs are in the young adults. So out of about 6 patients in need, 1 is a congenital, 5 are rheumatic adults. So it's of course emotionally much more appealing, and a team flying back and say we saved 6 children now feels good. But it's not a good solution, because most of the congenitals need complex post-care, and very often it was not even a success then in the long run. So that switch of mind from kids to rheumatics was our first real task as CSIA. And the second task was what needs to be done to help create local capacity. So that brought us to the point where we say, okay, now we have all the societies coming together, having come together, forming that alliance, and now we need to develop criteria which can guide other NGOs, or let me say NGOs because we are not an NGO, in the way they approach the translation of their good intentions into good results.
So the CSIA then is an umbrella organization really that's been ratified by the EACTS, the STS, the AATS, the
Asian Society and the Latin American Society.
Okay, and the World Heart Federation. Fantastic. So coming out of the Cape Town Declaration, you formed this alliance, you recognized the needs and the next steps, and so you took applications for pilot sites for your efforts, is that correct? And then you chose two. It sounds like Mozambique and Rwanda were the locations. And what's the status of those programs at the moment?
Before coming to the status, I need to emphasize that, again, CSIA is not an NGO. Yes. It's almost a guiding control body. But at the same time, we needed to demonstrate what we had in mind. And therefore, we said, for a short time, we also act almost like an NGO to prove that it can be done very, very different. The status of Rwanda is under the mentorship of the Americans. Mozambique is under the mentorship of the University of Cape Town, so I can talk more about Mozambique. And even the details of this translation of an idea shows that time is always much longer than one wishes that things take. But after we selected the site and criteria were that the government is fully supportive, the hospital administration fully supportive, that you have a local champion and a mentorship agreement with a middle-income country where they have rheumatics. All that is in place, and the government came on board building a new ICU, a cardiac ICU, Mozambique is the third poorest country in the world. So it means something if the government says, we made a commitment. And in that regards, the idea of the CSIA really played out because we were always hoping that the societies bring weight to the claim. And it resulted in convincing industry that they need to come to the party. So we got, in the first round already, 100 heart valves donated. It's just 100 heart valves, but it's still probably more than any single NGO would have got, because the companies know that this is a properly administered program. The government has also agreed that we gradually double the caseload. We help with consumables here or then. But what the mentorship also means is that teams of perfusionists, intensivists, surgeons, cardiologists can come at any time, and they do, for a month or two, to an institution with a high load of rheumatics, which is the University of Cape Town. And in return, we send teams like a mission, but not being a mission, because we don't operate. We are there, scrubbed in, hands off, and allowing them to line up more and more difficult cases for the time when we visit.
Sure. And so that's been the first few years of the CSIA, of course, slowed down by the pandemic. And what do you expect next from CSIA?
It is important for the next steps to remember that the societies never undertook to become an NGO. So the NGO part was a demonstration part. Our real goal is a seal of approval. Okay. That means that out of the many, many NGOs, if they are interested in getting the seal of approval of CSIA, to know that their program is endorsed by all major societies towards sustainability. I think that is a lot, and a program with that seal should be in a much better position for themselves to get contributions to sustainability.
And do you see CSIA as being a resource, a connection point to bring together these programs that you call the partnership program, like the University of Cape Town to the hospital in Mozambique? Will they be the ones that put the connections together to maintain these criteria that you mentioned?
Absolutely. So the first step is like, are you a democracy or not? Okay. That we can create collaborations between democracies. So therefore we have these basic principles. Mm-hmm. And once a program subscribed to the basic principles and got the seal of approval, we will increasingly provide a platform of networking where we will identify, we have already identified quite a few, identify training sites where a low-income country can send a resident to a high-volume center, but high-volume rheumatics, not high-volume 90-year-old aortic stenosis. Sure. Or what we discussed in today's meeting was to establish electronic teaching basis, but also identify training sites which know that they would get a team for a week or so for wet lab training, but all that always with a view towards the patients they treat at home and not just learn about the patients we treat in Vienna or in Washington.
Sure. I think that's a critical difference, right? That strategy to twin them with a hospital that has the same pathology that they see in their home country, correct? So it's an exciting time then for CSIA because you're sort of moving to the next step, correct? From all of the initial legwork that you had to do for all the ratification from the different societies and making that next step from, like you said, you're not an NGO, you're going to be basically providing connections and a seal of approval all geared towards sustainability in this global surgery sector. So it's an exciting time. Where can we look for more information? I know there's a paper coming out soon about CSIA.
We have really tried from the very beginning to continually publish where we go with our example case. Mm-hmm. And also published again and again the criteria which we believe should be adhered to. And the fifth of these publications is coming out now. And to demonstrate how enthusiastic each of the societies is to be on board, their journals, from the Annals of Thoracic Surgery, Cardiovascular, European journal, Asian journals, they always simultaneously publish our papers, our releases and updates.
It's fantastic. What a global source of support. Is there anything else that you think our audience should know about CSIA?
No, I think the most important thing is that people are aware that this is a process which takes time. You can't say after 2 years, where are the numbers? Show me the numbers. What is much more important is that the foundations are laid and the numbers start now speaking their own language. But it took time, and it will take again time until all the things which we, for instance, discussed today in the board meeting will materialize. But most important is the enthusiasm of the members of the societies which participate. In the beginning, it were the presidents. That was the big bang. But now it's sort of the bone work.
Right.
And it is very encouraging to see that those really with the feet on the ground are flocking to the CSIA idea.
Absolutely. Well, it's going to be exciting to watch the evolution of CSIA. Thanks for chatting with us, Dr. Zilla, here in Vienna. Hopefully we'll get an update here in the future.
Thank you.